We are live now.
Okay. Thank you, Rishi. Good morning, everybody. Welcome to another session on the art and science of pediatric orthopedic examination. Today we'll study about physiological variations in sagittal and rotational planes, and we have Dr. Chintan Doshi from Mumbai. Thank you, sir, for taking out your time. And so we'll go ahead with the session. There are a few polls. So sir has shared the options in the WhatsApp. So the participants can join on the WhatsApp or in the chat here. And the questions, we can put it up and we can take it as when the in between the chat talk. Okay, sir.
Sure. Joyance, can you see the screen?
Yes, sir.
Okay. Hi, I'm Dr. Chintan Doshi, a pediatric orthopedic surgeon from Mumbai. And today we'll be discussing on the coronal and torsional alignments in lower limb in children. And this talk is basically an examination talk. Not much of radiology and other findings are there. This is basically how we will examine a child when he or she walks into your clinic. In a specific case of coronal torsional malalignment, and what are the physiological variations in which we have to look into, and what are the red flag signs. So this is basically what we'll cover today. There are some questions which are interactive quiz in between the talk. So I'll pause the slide for 5 seconds, 5 to 10 seconds. You can answer it either on the WhatsApp group. That's a one option. The other option is the chat box on this. And if you have no access, don't have access to both of them, if you're seeing it on YouTube, you can just jot down the answer, and then as we progress with the slides, we'll make it more clear and the concept will be more thorough in that aspect. So going ahead with the talk, we often see this kind of children walk into our OPD, and we see so many deformities which present to us. What are normal and what is abnormal is might very confusing, because they present at different age groups. They may present when they are just started walking. They may present at a later date of toddler, or maybe in an adolescent age group. So to know what are the physiological variations is very important. As a pediatric orthopedic specialist, as I said, we see a lot of these children present to us with deformities. Only a few of them actually would have a pathological or a concerning deformity. Most of them would lie in the physiological range, but still it is always better to examine them and not consider them as, a normal without examining in thorough details. So looking at the deformity, we always scratch our head whether it is a triplanar deformity, whether the deformity only exists in a coronal plane or a transverse plane, that is the third dimension, or in the sagittal plane, which is a procurvatum or a recurvatum deformity. Our further examination points will make it clear and identify the deformity in these planes. So lower limb conditions of coronal plane deformities are common, as they are easily noticed by patients when the child is walking or standing, and they are brought to clinician most often in this coronal deformities. Rotational sagittal plane deformities are less noticed by ignorant parents. However, they may be unmasked when you're examining the child, and may be more visualized when you see them in thorough details and in slow motion. So what is normal development? In coronal plane, all of us know what we have been studying over the years, that as a child is born, there is physiological varus. And as a child grows, it evolves into valgus and then going into a normal alignment. And how this happens over a period of ages from birth to pre-adolescent age group is such that the varus which is present at birth usually resolves, and if it is physiological, usually resolves by 2.5 years of age. This is then replaced by valgus looking legs, which is maximum at the age of 3 to 4 years. After 4 or maybe around 5, it starts to resolve. So between 5 to 7 years, the valgus gradually corrects if it's physiological. If it is pathological due to rickets or any other metabolic condition or other problems, the valgus would not correct, and those are the patients which we have to identify and look in thorough details and have to follow it up to see whether they are improving or not. Beyond 8 years, the rotational deformities are less likely to completely remodel, and these are the ones which would require some intervention if they are grossly abnormal. So we have a very good paper with our mentor, Dr. Binoti Sheth from Sion Hospital, and she looked into normal development of knee angle in healthy Indian children, a clinical study of around 215 children. And what she also observed is what is there in the literature, that the physiological virus would rarely present beyond 2 years of age. And the Indian girls overall show more valgus alignment of knee as compared to boys. These are the two most important points from this paper. That normal, so this we saw in coronal plane. Normal alignment in axial plane also develops as the child is growing. So when the child is in the womb, in the human position, we know that the hip and knee are flexed. To accommodate inside the womb, the hips are a bit external rotated. So when the child is born, you will see that hips and thigh are bit external rotated than normal. As the child starts kicking and growing in height, the legs straighten out. But at this point in time, the femoral neck shaft angle, that is a anteversion angle, is around 40 to 45 degrees at birth. So the in-toeing will unmask when the child is walking. So, and the child is sitting. So child will sit in W position and the child will walk with a little bit of in-toeing when he begins to walk in a toddler age group between about 1.5 to 3 years of age. As the child grows in height, the anteversion angle corrects from 45 degrees to a normal adult angle of around 15 degrees. And the in-toeing will also gradually correct. The double sitting will evolve into a cross-leg sitting posture, and the child will become a normal adult in that sense. So by the time they are adolescent, or above 8 years of age, the thigh foot angle or the foot progression angle is about 15 degrees of outward direction, which is normal in an adult. It's not progressing. Okay. So now that we know this is not hard and fast that at 8 years it will be this, or at 4 years this will be this, but there could be some variation. So there are a range of acceptability which has to be known. So as we already discussed in the last few slides, bowing should resolve by 2.5 years of age. But beyond 2 years, if the bowing has become significantly less than what the child had at 1.5 years, you would still wait and not suggest that the child needs to undergo an intervention. So it is also how the deformity is progressing and whether it is in that acceptable range of correction. Parents must be concerned. They would be like, intervene, do something. It's not normal. The other children, because they tend to compare the neighbors, the previous child, or relatives. But reassurance to this parents is much needed when it is in the physiological range. So this is our first interactive quiz question. So as I said, either you can reply to the WhatsApp group ABC, or you can just reply in the chat, or you can just note it down. So parents bring this 18-month-old child to the clinic with concerns of severe bowing of both legs. And they noticed this when the child started walking at 1 year of age. So what would be the further line of management? Would you ask them to directly come after 2 years, tell them that this is normal, and just come after 2 years if it still persists, we'll see, or you'll do further detailed examination, or you'll start doing investigations, do lab radiology, see for other findings in that case. So we'll just pause for 5 seconds. You can answer this and then we'll go ahead. Right. So there is no true answer to this. It is not like you would just neglect and you will say that, no, this is normal at 18 months. I don't need to see the child. You come directly after 2 years. So that may not be the right thing to do. A detailed clinical examination, at least to identify whether it is falling in the range of, pathological, like, developmental problems or rickets or metabolic issues is something which is suggested. Also, directly jumping onto investigation without doing a thorough detailed clinical examination is also not right. So directly advising them to do a rickets profile or a radiology without actually knowing whether those signs and symptoms are actually present in the child is not also right. So
So
doing further
Chintan,
detailed examination would be a right answer first. And if
yeah.
you find signs of rickets, yes, you can go for radiology and labs. That would be the ideal way to go about it.
So Chintan, can I ask something?
Yes, sir.
So again, an 18 months old child comes with bowing, and we know that around most of the children should become straight by 18 months. Uh, the average age of getting to a rectus alignment between 18 and 24 months.
Yes, sir.
So my practice is to get an X-ray, at least because for subtle rickets, they will not show clinical signs of this metaphyseal swelling or costochondral swelling.
Right,
So
sir.
we get an standing X-ray if it is possible to make sure that is not ricket. That is one, and then it can become a reference point for future.
Future.
So we tend to get an AP X-ray. If child can stand, then it's standing. Or if not, then lying down.
Yes.
Not we don't get the lab test because whatever the lab test is, if there are X-ray findings,
Right, sir.
we do the therapeutic. But detailed can you elaborate on what other clinical examination?
Exactly. So,
And another point is history also. No, we have to look into other siblings. So kindly elaborate on that, please.
yes, sir. So that's what I was coming to. So doing a further detailed examination will be the first step. Knowing whether the signs are present or not present, you would go ahead with doing lab and radiology, or whether the only X-ray would be required. But first is to know about, doing a detailed examination is most important. So the question was put in that reference itself, that first clinically examine the child. Just because he has bowing, no, don't directly send it for radiology. Look at other joints, look at how the deformity is, how severe it is, and also ask the history whether it has been correcting over the past 6 months or not, whether it is better than what it was at 1 year of age, and how it is progressing. So all this is important. So the next slide answers this question. So look for detailed clinical examination. Look if it is bilateral. Look, both the sides are symmetrical. One side is more, one side is less. It would suggest that there would be some pathology. Look for signs of rickets, if at all there are any on clinical examination. Look whether it is uniform bowing. Look whether the deformity is more in the proximal part, or it is more in the distal part, or it is just the internal torsion that you are looking at, which is appearing as a bowing to the parents. So this also is very important. Look how the child, how it has been progressed. So you ask the question, how is it since last 3 months? Has it been better? Has it been worse? Or how is it, going ahead, how it's going to be? Look how the child is walking. So while walking, if there is thrust, a varus thrust, definitely there is something wrong. It may be ligamentous laxity. It may be Blount's, which is, quite a severe varus where the child would walk with a varus thrust. Look overall height of the child. In cases of achondroplasia or hypochondroplasia, the overall height is below the second standard deviation. A short stature, and in these cases, genu varum is very common. So look for that. Look for these kind of findings. Look for metabolic disorder history, whether a child had any nephrotic syndrome at, in the infancy, whether any medicines were taken for any other conditions, which would suggest that whether it is renal rickets or something which, which also needs to look into. So this is very, very important. So you have to do a first clinical examination, a detailed clinical examination. I'm coming to each and every point. So we are looking at how to do a cover-up test. So as I said, look where the deformity is most prominent, whether it is in the proximal leg or the distal leg. Now, how will you do this? So it is a cover-up test is the one which helps you to identify within physiological and pathological deformities. Also, it will help you to identify whether the deformity is in the proximal around the knee, or there is just simple internal tibial torsion. So this is a test to qualitative assess the alignment of the lower leg with related to the upper leg or the thigh, helps to differentiate between these two deformities. So this is just an example. So I'll just share it with you. So you see, I made the child lie down and it was looking quite bored, but on my clinical examination also I thought it was more in the lower leg, lower part. So we did the cover up test, and the upper leg with relative to the thigh is almost in neutral or even somewhat in valgus alignment. So this is a normal cover up test. So this is how you interpret this test. Once we do a covering to the lower half of the leg and look at the upper half with relative to the thigh, if it is positive, which means the first clinical picture here, if there is a varus alignment, which means there is a pathological bowing, or at least we know that the bowing is occurring at the knee, and this needs to be looked into. X-ray is a must here to look into the signs of uh, varus, where it is occurring due to Blount's or maybe due to rickets around the knee. The second picture here is a negative test, which I showed you in the previous video. So here the upper leg is relatively in valgus alignment or in a neutral alignment to the thigh. This is physiological, or at least the deformity is not in around the knee, it is somewhere below, and it could be an internal tibial torsion as was there in the previous case. So this is a cover-up test which will help you to identify between where the deformity is lying and how severe it is. Again, yeah. Okay. So the other thing that will help here would be an intercondylar distance. So these are all clinical signs. Obviously, the X-ray will help you to identify tibiofemoral angle. But what we are looking at is a clinical examination per view of these coronal and rotational deformities. So intercondylar distance is a distance which is measured at the level of the joint line. You can also measure, in some literature, it is mentioned at the level of the most prominent part of the distal femoral medial condyle. A joint line is something which is constant and will stay there. So I would prefer to do it at that level. So to measure the distance between the medial most part of both the joint lines when both the patellas are faced forward. Now, this is the most important thing. Patella facing forwards is the most important when you are checking for genu varum, genu valgum, because some of these deformities will be masked with the position in which the child is standing. You know, if he is facing patella inwards or outwards, the deformity will look less prominent. So this is the most important. You can measure the distance and then see gradually as the child is growing whether it is becoming all right. An intercondylar distance of more than 6 to 7 centimeters after the age of 2 years needs further workup, needs to look into more details, because that is not normal. It should go to almost normal, or at least the knee should start touching when the child is turning into 2.5 to 3 years of age. So for genu varum, what are the red flag signs that we saw? If it does not resolve between 2.5 years of age, you have to do further investigations. You have to look into the pathology. Look for significant unilateral involvement. So if one side has more deformity, more prominent, or only one side unilateral deformity is present, which means there is something to be looked into. A varus thrust, I already mentioned. Signs of metabolic conditions, I mentioned. Severe short stature, again, achondroplasia and hypochondroplasia. So these usually have bowing, and it does not resolve as the child grows. Again, cases of skeletal dysplasia. So these are where the other joints also will be involved. So you look into the entire child, not just the knee. So this is something that is to be looked for as red flags in all cases of genu varum. Coming to Blount's disease, this is a typical deformity. Now you see here, if you do a cover-up test, the animation is not working. Okay. So looking at this child, when we do a cover-up test, you see that the left side has quite a severe deformity, and it is around the knee. When the X-ray is done, definitely you can see the signs of Blount disease. A tibiometaphyseal angle of more than 11 degrees suggests that this would evolve into a Blount's disease, and a tibial plateau which is sloping and partly lytic is again a sign of Blount's disease. So these are the radiological signs. We are doing what today's talk is about is examination findings. So let's look into more examination findings of more such patients. So a 6-year-old child with a past history of nephrotic syndrome is on medications for renal problem and has presented with genu-varum deformity. So how we'll examine this child in clinical findings? X-ray shows a lot of problems and a lot of things. There is a problem in the hip, there is problem in the ankle as well. So there are deformities in the other joints. What we are looking at is clinical findings of this child. So short stature as compared to his peers of 6 years old, he is falling between 1 and 2 standard deviations, not below second standard deviation, but between 1 and 2 standard deviation. A short stature, intercondylar distance is increased at the age of 6 years. A tibiofemoral varus angle of around 25 degrees is present. Cover-up test shows that the deformity is around the knee, so it is pathological. And other joints are also affected. He's walking with a lurch, walking with a Trendelenburg gait. Hips, the X-ray shows coxa vara, so hips are affected, the ankle is affected. So these are all the red flag signs that are present in this child, and this would need treatment because he's already past that physiological age of 2.5 years where the virus would correct by itself. Plus, he is a case of nephrotic syndrome, a renal condition, which would further, the deformity will further increase if it is not corrected in time now. Now, so those were the cases of genu-varum and clinical evaluation in case-based format. Now we go for genu-valgum. Genu-valgum also has specific and special tests which needs to be done. A genu-valgum is physiological when it occurs around 3 to 5 years of age, as we saw when the normal development happens, as a physiological development happens. There would be gradual resolution of this mild valgus over a period of years and would achieve a normal mature alignment of adult of around 7 degrees at around 7 to 8 years of age. The appearances can be deceiving. Sometimes the valgus may not be present at the knee. Increased femoral hip anteversion or external tibial torsion, flat foot or ligamentous laxity would present as a genu-valgum. When you see the knee in lying down position, there would not be actually a deformity at the knee, but other rotational deformities, other problems would be seen. So this is what we have to look into when we are doing clinical examination. So as we already mentioned, children less than 7 years could be a physiological if they are in the growing age and it is becoming better over a period of time. Again, less than 7 years, but the valgus is progressing. Like at 6 years, it was less, and parents present that now it is becoming more. That is also a red flag sign. So don't disregard that. Okay, the child is less than 7 years, nothing. It's going to be normal. If it has been progressive, if it is asymmetric, if it is something that has happened post injury, you have to have a long-term follow-up. So it is important that we see the child over a period of time in such cases. So children less than 7 years, symmetric, stature greater than 25 percentile. Again, a tall child would sometimes have valgus because of the posture. One. Second, the angle that the knee makes in a shorter child would not look so severely valgus as it would look in a taller child. And the tibiofemoral angle of less than 15 degrees and intermedullary distance of less than 8 centimeters in a child less than 7 years old is usually physiological. Now, as we mentioned in the previous slide, what is intermalleolar distance? So intermalleolar distance is calculated by unmasking the actual deformity by placing the patella. Again, as I said in genu-varum, here also facing patella forwards is the most important step. So make the child lie down or stand, but make sure the patellas are facing forward. Then what the deformity is unmasked. measure the distance between the two medial malleolus. And in this clinical exam case, it is about 18 centimeters. In a normal child, it would be less than 8 centimeters. What I also follow, and what is there in the literature is a rule of 10. Intermalleolar distance of 10 centimeters at the age of 10 years would need detailed examination if it is progressive and if it is increasing. Below 10 centimeters at the age of 10 years, you would just closely monitor this child. Variations as per age, sex, and growth spurt are also to be looked into. If there is precocious puberty, if the girl has achieved puberty at 9 years of age, then this rule will not follow. So age, sex, growth spurt, how the child is growing, also that is very important. Then what is clinical tibiofemoral angle? So clinically, long axis of thigh and long axis of leg should be in straight line. If there is a valgus at that, and this is calculated at the center of patella as a center point. Again, this is to be done with patella facing forwards. So tibiofemoral angle of greater than 2 standard deviation outside of mean is abnormal. And however, this is most accurate on radiology. So clinically, because they may have a bigger thigh, the center may, because of the fat, may vary, but the tibiofemoral angle on radiology is better judged to deformity than clinical. In genu valgum, another special test that we look into clinically is on clinical examination is a Q angle. Q angle is a angle formed between a line joining the ASIS to center of patella and center of patella to the tibial tuberosity. Normal Q angle is about 14 to 16 degrees in male and 16 to 18 degrees in girls. So what does the Q angle specify? So Q angle is important as it gives assessment of angle of quadriceps action. Due to this, there could be patellofemoral joint kinetics which may hamper because of the pull of the quadriceps in an inappropriate angle. There would be increased incidence of anterior knee pain. Increased Q angle may also suggest that there are chances of increased risk of patellar dislocation or subluxation. So, and these are very important in cases of genu valgum because sometimes the child may present with a subluxating or dislocated patella. The valgum may be looked into later when you do a thorough clinical examination. So, in all the cases of genu valgum, looking at patella and patella tests is very important. Look for apprehension, look for patella glide, look for patella grind. Because of change in kinematics and angle at the knee, there would be, as I said, increase in Q angle would lead to anterior knee pain in adolescent age group, and this will be seen in clinical examination as well. So what are the red flags in genu valgum? If the valgus is increasing even after the age of 7 years, if it is asymmetric and intermalleolar distance of more than 10 centimeters, valgus, which is unmasked by external rotation gait. So the easiest way for the child to mask the valgus is to walk with feet facing outwards. The knees come closer and feet come closer. The valgus is almost more or less disappeared. But once you put the patella forward, you will see the actual valgus being unmasked. Other joint involvement, as we do for genu varum as well, metabolic conditions and patella problems are very specific to genu valgum deformities. Now, once we know that the valgus is present in a growing child, the growth modulation is one of the treatment in which we would correct as the child is growing. How would you do an examination of a child who's operated with growth modulation over a period of time? So this is just to show that make a chart to look at IMD or intercondylar distance over a period of time. If you are not doing surgery, at least do it 3 monthly or 6 monthly and look whether it is improving. If it is physiological, it will improve, or if it is just metabolic and you're given corrections of vitamin D and calcium, it would still improve. So look at correction of clinical signs and also radiological signs. So look for correction of tibiofemoral angle on X-ray also. So X-ray findings. And if you have operated, look for complications. Look for, so you always have a column of complications in your chart so that you know if there is any backing out of screws, any if you are using staplers, if there is backing out of staplers, you will see, mention it on the paper, and you will see the progression, how it is going. So have clinical, radiological, and complication everything on one chart, on one page, and it will be better to look into over a period of time. Now, in any coronal or torsional deformities, hyperlaxity is something that we have to look into most common. This is our second question. So, which of these is not a feature of beaten score? You can answer it either on WhatsApp or on the chat here. So, apposition of thumb to flexor aspect of the forearm, hyperextension metacarpophalangeal joint of middle finger of more than 90 degrees, forward flexion of spine with knee extended, allowing palm to rest on the floor, and recurvatum in the knee. You just hold it for 5 seconds. So the next slide is to give you the answer to this. So beaten score, it describes a total score of 9. One is thumb touching the flexor aspect of the forearm. Okay, this is the point, and for both. So this has 2 points for the left and for the right. So if it is present for both, then 2 points for this. Then looking at the little finger, so hyperextension of little finger metacarpophalangeal joint of more than 90 degrees is 1 point each for each side, left and right. Elbow recurvatum is again left and right, 1 point each. Knee recurvatum, both left and right, 1 point each. So now we have 8 points for these 4 signs. And the 9th point is for the spine, which is flexion, such that the knee are straight and the child is still able to touch the entire palm to the floor. So that is 1 point for the flexibility around the spine and the hip. So total of 9 points. If it is less than 5, it is normal, because that is physiological laxity which happens in younger child. But if it is more than 6, then you have to look into whether the valgus or the varus or the deformities are exaggerated because of ligamentous laxity. So these are the signs of hyperlaxity of joint. Now we discuss about torsional profile. Again, we have few questions here. So which of these is not a test for assessment of lower limb torsional profile? So A, Craig's test, B, thigh foot angle, C, Q angle, or D, foot progression angle. I hope all of you have answered. We have one more question on this. So which of these tests is not for femoral version assessment? Is it the Craig's test? Is it the thigh foot angle, hip rotations, or the Ryder's test? So next few slides will clear both these questions. So we go into looking at case-based examples of assessing the torsional profile of lower limb. So this is first case where the child is walking. Parents have got this child to us because the child is walking with the in-toe gait. So that observe the gait, and this is the second child. Yeah. Okay. So what do you think? Who has a torsional problem? So case 1, case 2, we see that the foot progression angle is pretty much straight. Child is walking. Now you will see him coming towards us. Yeah. Okay. So you would see, Joyance, are you here?
Yes, sir.
Yeah. So thigh
Case
foot
1.
angle, yeah. So thigh foot angle in which child would be abnormal? What do you think?
Case 1.
Right. So all of us think the same way because he's toying with such a lot of intorsion. Now, when we make the child lie down and sleep, the thigh foot angle per se on case 1 is actually normal, within normal range. On the case 2, there is 25 degrees of internal rotation. This is by Angular's app. So I just made him lie down, same child, made him lie down, 25 degrees of internal tibial torsion. Now, what is happening here? Why are we seeing this? We are seeing a child with in-toeing, but thigh foot angle is normal. We are seeing a child with normal gait, just there is some bowing in the tibia, but you see a internal tibial torsion here. So we'll go into details of this. Both the cases will give us the thorough idea on how we examine the child in a torsional profile. So the torsional profile, you see the gait, which gives you the total assessment, a total combination, addition, subtraction, everything from femur, tibia to foot. So if there is femoral anteversion, but it is negated by external tibial torsion, the gait will still be straight. So a gait, that is a foot progression angle, will give you the assessment of an entire lower limb, all the deformities together. Craig's test or a Ryder's test, both of them are same. They assess femoral anteversion. I have a clinical videos to all of these. I'll show each and every one of them in subsequent slides. Hip internal and external rotation is for, that is for femoral, again, femoral anteversion. So Craig's test, Ryder's test, and hip internal external rotation, hip rotation test, all of these are for femoral anteversion. Thigh foot angle per se is only for tibial torsion, because you make the child lie in prone position, flex the knee, the femur is ruled out. Whatever is the deformity, torsional problem is in the tibia here. So thigh foot angle is for tibial torsion. Heel bisector line is for foot torsional problem. Intermalleolar intercondylar axis superimposition is for, again, tibial torsion. That is not very commonly done. The first 5 are most commonly done for almost every child with a deformity. So we saw this child, right? So a normal foot progression angle would be about 10 to 15 degrees of external rotation, or placing the foot straight or a bit outwards while walking. Now this child has a abnormal foot progression angle, which is about 15 to 20 degrees of internal. So it's minus 15 to 20 degrees of foot progression angle in this case. Now, how do we check for the femoral anteversion? So by Craig's or a Ryder's test, you make the patient lie prone, flex the knee, palpate around the greater trochanter, turn the leg internal and external rotation till the time you palpate the greater trochanter in its full. Okay, here. Right. So there. So there is where the greater trochanter is maximally palpable. Now, when we check this with the vertical at that angle, this is almost 40 degrees in a 5-year-old child, which is not normal. I forgot to mute this down. Yeah, the other things I muted, but this one I couldn't. Okay, so when we saw, when the greater trochanter was maximally palpable, the long axis of leg makes about 38.9 degrees with the vertical, which is the femoral anteversion in this child. So that is one. So that is Craig's and the Ryder's test. The other way to see femoral anteversion is by looking at internal and external rotation of hip in prone and supine both positions, so as to know whether one of them is higher than the other. So normally it will be nearly equal, maybe 40 degrees of each or 45 degrees of each. What happens is, in femoral anteversion, look here. So when the child is in prone position, the internal rotation is almost 90 degrees. Both the legs are almost touching the bed when we are doing complete internal rotation. The external rotation per se is just 15 degrees. Beyond this, the child is unable to do. So these suggest that there is increased femoral anteversion. Okay. Same thing when we see with the child supine and hip flex to 90 degrees. Again, you see the hip internal rotation. It's almost 90 going into 95. And the external external hip rotation is about 30 to 40 degrees. So that is also the asymmetry between internal rotation and external rotation of hip. This also suggests that there is hip anteversion issue with the child. Other thing that I do is ask the child to sit how he normally sits at home. So make him stand, ask him to sit. The first thing he assumes is a position of W. Now that is the most comfortable position if the child is sitting. So I just asked him to sit. The first thing that he assumed was W. Then I had to tell him, okay, make it cross leg. He is unable to do a full cross leg sitting as well. Because of increased femoral anteversion. This is almost a 5-year-old child. Again, the another child, same. W sitting is comfortable, cross leg sitting is not possible. So this also suggests that there is a torsional problem of femoral anteversion. Then going to tibial torsional problems, we look at thigh foot angle. We saw in the previous example of the two cases. You make the child prone, flex the knee to 90 degrees, and then calculate your angle of long axis of foot to long axis of thigh. If there is internal tibial torsion, you will see that the foot is faced inwards. So here, the second case, the same example that we saw with the child walking. Here, as soon as you flex, don't touch the foot. Just see in what position the foot is along with the thigh. So this is about 25 degrees of internal tibial torsion. So that is abnormal. Normal tibial torsion is about 10 to 15 degrees of outward facing, right? So that is for thigh foot angle for tibial torsion. Now looking at the foot torsional problems, the test that helps is heel bisector line. Draw a straight line from the center of the heel, bisecting both the center of the malleolus and going straight line where it intersects. If it intersects between the second and the third toe, it is normal. Anywhere, if it intersects beyond the fourth toe, there is a adductus problem in the foot. The leg, the thigh, and the tibia would be normal. But if this is there, then it means a deformity, the torsional problem exists in the foot. So normally it would cross at second and the third toe. However, in adductors, it would cross at or beyond the fourth toe. The other angle that we saw was the transmalleolar and the transcondylar axis. So B and C is while keeping both the femoral epicondyles in the same plane. Look at the axis that both the malleolus make with it. So A and B are medial malleolus and the lateral malleolus. So a line joining the medial malleolus and the lateral malleolus. This is by superimposition. So you have to look from end on view from the top. And this would determine tibial torsion. Again, the foot deformities are out and the femoral deformities are out. This, like a thigh foot angle, would just determine the tibial torsional problem. So examination of a child for knee coronal deformities and other torsional problems is extensive, involves to find out intricate findings like special tests like cover-up test in genu varum, Q angle and genu valgum. So these are the tests which are required to do over and above what we normally do for the other lower limb examination. It is important to include all the important findings pertaining to the case to complete the clinical examination. I'll share a chart where this is there in one of the textbooks. So this is for rotational profile and angular deformities. However, this is also not complete. You need other things also to identify the problems coexisting with the angular deformities and also look at the other joints, joint above, joint below, and the overall metabolic profile of the child. Thank you.
Thank you so much, sir. It was a very interactive and exhaustive session. We have a few questions in the chat, so can we take them up?
Yes, sir.
So, Dr. Puneet had asked on starting treatment for nutritional rickets, how much time is required to see noticeable change in deformity and for complete correction?
Okay. So, depending on how severe the rickets is and how severe the deformity is, if you see a very gross bowing where intercondylar distance is more than maybe 8-10 centimeters, you would see corrections happening quickly in the initial space when you have given how we are treating. So we have what is called a Strauss regimen where we give 6 lakh units in the first presentation if the child is above 3 years of age, and then we give oral substitute as well weekly, and then also give calcium along with it. So you see clinical corrections over a period of 3 months. So I don't tell them that I've given you medicine today, in a month there would be some significant improvement, but noticeable change and significant improvement will be seen over a period of time. So X-ray findings, yes, it is 3 weeks to 6 weeks. You will see those signs of rickets in the form of cupping, splaying, everything getting corrected, and the distance between the epiphysis and the metaphysis also reducing in about 4 to 6 weeks. But the clinical change would be somewhere around 3 months over a period of time. And I usually call them at 1 month follow-up, again 3 months, 6 months, and 9 months. So in that way. And again, if it is not correcting, always suggest that do a closer follow-up than what is regularly told to them.
Yes, sir. Thank you, sir. So Maulin sir had asked for that slide in which there are these children standing age-wise, and there is the
first one, okay.
varus valgus alignment. So if you could share that
Yeah,
slide with everybody.
I'll do that.
I think from
I
till
think the first
adolescent.
few slides,
Yes, sir. It was on the first few slides.
I'll share.
Okay. So another question was, sir, this IMD and ICD, so do you measure in standing always or in supine also?
Both. So I tend to do in both.
Okay.
And standing, you most commonly gives more, just a minute, I'm just placing the slide.
Okay.
I'll share it with. Yeah, so standing I prefer, but I do it in both, lying down also and standing as well. I'm sharing the PowerPoint. Okay. Screen sharing has failed. Just a minute, I'll just try again.
So you can share that slide or that image in the WhatsApp group. So
In the
I think
WhatsApp group? Okay.
everybody can access that later too.
Sure. Yeah, I could share it. So there are two actually. This is the one.
So I think this was the one which sir meant. Like
This is
all
the one. So 1 year, 3 years, 6 years, 12 years over a period of time. And there's one more, which is this.
Okay, sir. Yes, sir. I think
Both
are.
of them.
Yes.
I'll share it. I'll share them on the group as well.
Yes, sir. Yes, sir.
There was, yeah. So the other question was in lying down and in standing, right? So
Yes.
I do it in both, but do it with patella facing forwards. That would be my suggestion, because many a times we see that, there is difference. Someone has measured it as maybe 8 centimeters, but someone is getting as 10 centimeters. Just keep the patella facing forwards or facing the ceiling if it's in lying down position, and then do the measurement. And I think almost always will be getting a right answer.
Yes.
Anything else? So those are the slides I have to share, right?
Yes, sir.
The physiological. Okay.
Yes, I think those two.
Okay.
Yeah.
Any examination slide or video you need to share for better understanding, I'll do it, no problem.
Okay. So I think this was a very nice talk, and I think a lot of people who didn't join and those of us who joined also can always come back to refer to it. It will be on the YouTube channel too. So, there are no further questions. So I think we can conclude the session, sir.
Okay.
Thank you so much, sir,
Thanks,
for
Joyance.
taking your time. Yes, sir. Happy Dashera.
Yeah, happy Dashera to everyone.
Okay, sir. Have a good day.
Okay, yeah.